Welcome back to Close Up. On so many issues in Concord, lawmakers are firmly entrenched in their partisan positions. Votes are predictable. There's not a lot of crossing party lines. That's not so with a bill to legalize assisted suicide, what supporters of that concept call medical aid in dying. House Bill 254 would allow a terminal patient with mental capacity and a prognosis of 6 or fewer months to live to be prescribed lethal medication upon a voluntary request, which they must then self-administer. This issue comes with many layers of moral, legal, and medical questions. Here to discuss some of them today, Dr. Gary Sobelson, a physician who supports the bill, and Lisa Beaudoin of Strategies for Disability Equity. Thank you both for joining us on this very interesting topic today. Appreciate it. So, Dr. Sobelson, let's start with you. Why should this bill become law?
Well, I think the issue for me as a physician is that I'm witnessing patients suffering, the need for compassion at the end of life. And this bill offers us an opportunity to join 10 other states over several decades in offering a new form of help for patients to alleviate suffering and pain at the end of life.
And Lisa Beaudoin, what is your argument against this bill?
My argument against this bill is that the National Council on Disability, which is the independent, nonpartisan agency that reports to the President of the United States and the United States Congress, has issued a 77-page policy position stating unequivocally that these types of initiatives are inherently dangerous for people with disabilities and other vulnerable populations. They reinforce negative stigmas about life with disability, and in addition, there are a number of challenges with the existing laws that they cite in their paper.
And Doctor, what are the guardrails here? How would it be ensured that someone is not being coerced into this process?
Absolutely. I think the perspective of these bills, by the way, I would agree very much with what was stated. This bill does not apply to someone with disabilities who wish to end their life. The guardrails here require that 2 healthcare providers ascertain that someone has 6 months or less to live. It requires that the person be fully competent. It requires witnesses. It requires the ability to self-administer. It requires that there not be exactly the concerns that are raised, that anyone be coerced.
And Lisa, with all of these different layers of sort of security around this,
Sure.
What is your concern about someone in the disabilities community still
Sure.
entering into this process in perhaps a way they don't understand?
So it's not actually about individual people with disabilities. It's that the inherent messaging around why people want to end their life and what is described as a life with dignity or dying with dignity frames the very everyday lived experience that people with disabilities have in their lives as being lives not worth living, and it further entrenches discriminatory attitudes about people with disabilities. I will also like to add that 17 of our nation's top disability organizations, their policy experts all stand alongside the National Council on Disability that these types of initiatives continue to further marginalize people with disabilities. And I have to say that the nation's top policy experts can't all be wrong on their policy analysis. Suicide contagion is a real phenomenon. There is a loosening of rules effect. 5 states have loosened their rules, including our neighbor state, Vermont, which now allows people from other states to go there, which means that doctors that know their case histories intimately is no longer part of that safeguard. There's a double standard around suicide prevention that is also a deep concern for the National Council on Disability. And I'll take a pause.
Okay, well Doctor, what do you think about that? You know, how does one draw the line on mental capacity within this law, in particular, if it's a doctor who's predisposed to support the idea of medical aid in dying?
Yeah, I think the safeguards speak for themselves, and I am, very connected and concerned and care for people within the disability community. I'm aware of their concerns about the broader aspects of medical aid in dying and how it may apply, but I think now you have to take the other side of this and recognize that there are people who have end-of-life terminal conditions, particularly metastatic cancers, certainly some of the progressive neurologic illnesses like ALS, who are truly suffering. and my ability as a physician to help them at the end of their life is restricted by law to various forms of care, most of which, by the way, I would say are very effective. And I would not want to speak against the hospice level of care and other palliation, but this will give us another tool, and I think most importantly will give patients another tool to help them more adequately care for themselves at the end of life. And the data strongly suggests this is not a new or radical idea. It's an idea that's been in place for over 25 years in sister states. It has worked. It hasn't led to the concerns that, frankly, these experts, I think, are citing. While I absolutely understand that they have a very focused interest in the concerns of the disability community, I would be very much wanting to support a law that protects the disabled from any coercion from this.
So go ahead, Lisa.
So this isn't actually about wanting to protect people with disabilities from being targeted. We know actually that people with disabilities face discrimination within our healthcare system because 82% of doctors report that they believe that life with a disability is not worth living when compared to life with a disability. So our healthcare system has what you know, Dr. Sobelson, our health disparity populations. So people with disabilities, people of color, impoverished senior citizens are frequently squeezed out of care. So if you are squeezed out of care and do not have bodily autonomy in the first place, and you end up having a treatable condition that becomes terminal, you haven't actually had the choice to stay healthy in the first. We know that women with disabilities have a hard time getting mammograms and pap smears. We know that Black and brown women die at 5 times the rate of white women in childbirth. I think we are seriously leapfrogging over incredible gaps in our healthcare system by ignoring the need to deal with baseline levels of care at the expense of providing yet another option to those few folks who largely have already had excellent access to specialized care. I would like to see our nation's vulnerable health disparity populations get the basic levels of care that they deserve before, as a matter of good public health policy, we go and allocate additional options for those folks who've exhausted all of the best care.
It's an interesting expansion of the argument, and you may agree, but Dr. Sobelson, go ahead.
And I think that's the point. It's a wonderful discussion and a very important one that's being brought up, but it's not really relevant to the bill and to the, in my mind, to the question of the needs of the very few. This bill focuses on a very small group of people who need these services. It doesn't focus on people who are well cared for with end-of-life care under hospice or palliative care. It gives an option to a few people, and that's really the numbers that are seen in our sister states that have done that. And while I 100% agree with the comments about access to care and quality of care within the populations of concern that are being brought up, I don't think it's relevant to the bill that's in question.
What about other countries? Obviously, you know, people would worry that once this does get into law, we could start seeing that expansion. Obviously, in the Netherlands, there's been that discussion. There was a young woman who had chronic depression and I think was prescribed lethal medication. How do you stop that from happening once you get this in law?
I mean, I think that's all about the way we create our laws and how we enforce them and carry them out. I think our legislature is very capable of doing that. I think the language that's in the bill that's in front of them starts a great framework. I do think that there are other parts of the world where there are different values that are held about many things about health care. And again, sometimes they're ahead of us and sometimes they're behind us and leading us in the wrong direction. We'll all learn from that. I do think we have a number of states that we can learn from as well, including our sister states, Vermont and Maine, where these bills have passed.
And Lisa, what are your thoughts about, you know, what we see in Canada, what we see in Europe?
Well, I'd actually just like to point right here to our own country. I'd like to point to California, where Ingrid Tischer, a woman with a significant number of disabilities, had a respiratory infection. And her doctor passively steered her to take the lethal prescription when all she wanted was to go to rehabilitative care so that she could get the intense care that she needed after having a respiratory infection that had nothing to do with her primary disability. I will also like to point to Lonnie Van Hook, a black man, a veteran, who ended up a quadriplegic, whose doctor said to him, or whose healthcare providers also steered him toward the lethal prescription, and then he considered it. And, you know, these are two examples of the coercion that's happening in our country,
Now, Doctor, we'll give you the last word as we wrap up here.
I would hope that in both of those cases, which neither one I am familiar with, that proper authorities and licensure groups and the legal system would focus correctly. Again, I don't think it speaks to what we're requesting in this bill, which is that compassion and individual rights be considered as well.
All right. Lisa Beaudoin, Dr. Sobelson, thanks so much for your perspective and your time here on Close Up. We appreciate it.
Thank you.
All right. Coming up after the break, what Senator Shaheen is doing in Washington that points toward another re-election campaign. Stay with us.